Welcome to Occupations, the podcast, where we discuss what it's like to hold specific jobs. Occupations is brought to you by lotsofmaps.com, where you fulfill your vintage map gifting needs. Visit lotsofmaps.com.
Hi again, Andy Jagellons are here for Occupations. Thanks for listening. Today I have Stan Ducharme with me, and he is, hold on to your hats for this one, it's a long title. He is a professor in rehab medicine and urology, and a clinical psychologist specializing in sex therapy at BU School of Medicine. And he's also a psychologist at Boston Medical Center. Stan, welcome.
Thank you very much, Andy. It's nice to be here.
So we're going to talk about your job a little bit, and there's a lot there that I just said, so there's a lot to dig into. Tell me a little bit about, and you want to break it down into specific parts of your job?
Sure.
Or,
Yeah, my job has evolved over the years into different components, so probably be best to kind of break it down a little bit.
Okay, let's do that. Where do you want to start? You want to start at the beginning of your title?
Sure. Let me just, so I got my PhD in psychology back in the 70s out in California, and I started my career at New York University Medical Center, where I did a 2-year fellowship in rehabilitation medicine, which means that I started working with people who had physical disabilities such as spinal cord injury, brain injury, muscular dystrophy, cerebral palsy, etc. Back during that fellowship in the 70s, the idea of sexuality for people who had physical disabilities was just beginning to sort of evolve. It was beginning to, people with disabilities in the community were really frustrated that the medical profession was not addressing this issue. They would go through their rehabilitation in the hospital and then be out in the community, and their marriages were falling apart. They had no idea in terms of how to keep the intimacy in a relationship. And it really was people with disabilities that sort of started demanding from the medical profession that they needed to learn about how a disability affects their relationship, how it affects their intimate life, how it affects their ability to be a father, a mother, and a member of the family. So I got some training in that, and sort of that kind of got me started. And then after that fellowship, I moved to Boston and took a job at BU School of Medicine and Boston Medical Center, where I started emphasizing and doing that kind of work. So I got to Boston University, and again, it was fascinating that even at a school like BU School of Medicine, there were no courses for medical students on sexuality. They weren't being trained how to address these things as primary care doctors or in their role as physicians. So my wife and I started doing workshops and training programs in sexuality for the medical students at BU, as well as people working at Boston Medical Center. And we did that for maybe about 10 years until we started having kids, and our personal life didn't allow sort of us to be doing these kind of workshops.
Sure. So were you a trailblazer in this work, or were you part of a team that was sort of getting this work out to the public?
No, I would say that when I came to Boston, this was not something that was being done in Boston, and it was not really being done in most places around the country. There were a few places, such as the University of Minnesota, that had a training program. Had some professionals, so I traveled around the country and got additional training, but it was just sort of in the early stages, just starting to as something that should be addressed by the medical profession.
I know we live in an uptight country where sex is, it's certainly not a dirty word, but it's something that we consider embarrassing for some reason. Do you find that internationally, that we're the ones that are most uptight about it? Or?
No, I don't think we're the most uptight. I'll talk a little bit later, but later in my career, I started doing international consulting in a lot of third world countries and places. I mean, I've been to Saudi Arabia doing these trainings, and I've been to India a couple dozen times, and I think that there are other countries that are even more conservative around these issues than the U.S.
I'm sure. But we're still pretty sketchy about the whole
We're
thing.
pretty sketchy.
Yeah,
I mean,
all right.
it's not something that people are used to talking about.
Sure.
Even with their doctors, it's taboo in many ways.
Absolutely. So these workshops that you work on, you're not doing one-on-ones with patients. You're teaching the medical community how to deal with their patients?
Yes, we were teaching the medical community. Majority of my time is spent seeing patients individually, one-on-one or couples. And as people began to sort of become aware that we were doing these kind of workshops, people in the community with disabilities and their wives or girlfriends started coming in for sex therapy. So it was something that people didn't know where to turn, and that was something that I provided to them.
So where are we now? In the 70s, 80s? Where are we when you're talking about you did 10 years of workshops, and then what happened after
Sort
that?
of pretty much about 10 years of workshops, and again, I've been at BU for 47 years, so my whole career was there.
Wow.
And up until pretty much the 90s, early 90s, I would say I worked primarily with people who have physical disabilities in terms of providing sex therapy to them, along with sort of helping them with their adjustment to spinal injuries, brain injuries, etc.
Sure. So you recently retired from some of it.
Yes, I retired when the pandemic started. I retired from Boston Medical Center and from BU. And now I'm just doing a telemedicine practice from my home.
Great. And is that dealing with the medical community as well, or is that one-on-one?
My involvement working in sexuality has evolved over the years. In the mid-90s, I moved from rehab medicine into a urology department at BMC, Boston Medical Center, as a member of a Center for Sexual Medicine, again, in the urology department. So I then began to see people strictly who had any kind of sexual dysfunction, meaning erectile dysfunction, low sex drive, pain during sex, infertility, premature ejaculation, those types of patients. For about 10 years, I worked primarily with, again, people who had a sexual dysfunction, who were not necessarily disabled. There was a lot of people with anxiety, or they could have physical problems as well. One of the things that I learned is how easy it is to injure yourself, for a guy to injure themselves so that they have erection problems. I used to see a lot of people who play sports and would be hit in the crotch by a ball or a soccer ball, or bike riders who would be biking for long distances, who would sort of ignore the fact that they were numb in the crotch area and would develop erectile dysfunction as a result. So there are a lot of young people who are playing sports, or, again, who had a lot of anxiety, that type of thing.
I know it's going to be very different from patient to patient, but when dealing with this, give me an idea. Are we talking about medicines to help? Are we talking about rehab to help? Are we talking about psychological issues, or all of the above? What are we talking about as far as helping
We're
folks?
talking about a multidisciplinary approach in which there may be medicines involved, there may be surgery involved, and from my point of view, there's always a psychological issue involved. Typically, there's always anxiety. There's maybe depression as a result of the problems. There are marital issues or relationship issues that emerge. So my job with these individuals would be, obviously, to address the anxiety, the psychological issues. Again, issues like somebody that was sexually abused earlier in life.
Yeah.
That those type of traumas last throughout life, and if somebody had a trauma as a young person with sexuality, their sexual functioning is going to be altered, and it's going to be a source of anxiety for them, most likely, kind of throughout their life. So I worked with a lot of people who have post-traumatic stress disorder around sexual issues, and again, where the psychological issues were predominant. But even in those kind of patients, medications like Viagra and some of the other medicines for sexual dysfunction are very helpful to sort of get people started and kind of help them have some successes in gaining their confidence back.
For those that need surgery, I would assume you're talking spinal cord injury folks, potentially others as well. What kind of surgeries are we talking about?
Again, I'm talking more about people who have erectile dysfunction where there's surgery on the penis improves their blood flow into the penis.
Got it.
A lot of young people with erectile dysfunction are candidates for that type of surgery. Or they may have penile implants implanted. And that might be, again, a person with a disability, such as a spinal cord injury or cerebral palsy individual, or it just could be anybody off the street that has a chronic condition such as diabetes or whatever. If somebody's problem sexually is, let's say, more related to anxiety, post-traumatic stress disorder, things like that, surgery is not really something. It's a last resort, I would say.
Sure.
Those people you want to try and deal with through sex therapy,
Yep.
as well as maybe using medications.
Excellent. So, Stan, tell me a little bit about what made you get into this field. I mean, I know you went to school for what? What did you get your degrees in?
I got my degree in clinical psychology. But I would say that what really got me interested in, for 12 years, when I was an undergraduate and through graduate school, I worked as a respiratory therapist in hospitals in Connecticut and in California. So I became very familiar with the hospital environment, working with people who had medical conditions. So as I went into psychology, my interest was in working, again, helping people adjust and sort of develop a quality of life in spite of having a disability or in spite of chronic medical illnesses.
And do you feel like because there was a need for this and it didn't exist, was that exciting for you as far as a type of career versus maybe doing something that already existed?
It's been very exciting. That has been a big part of the satisfaction that I get from this, is that the patients that I've worked with really who maybe have never been able to find a psychologist or sex therapist to talk about these kinds of issues, have always seemed to been very appreciative of kind of that opportunity to address this, to talk about it, to work on these things.
So that actually leads to another question about the results that you have with some of your patients, with some of your medical folks that you talk to. What kind of successes are you seeing? I don't know if you have statistics, if things are getting better, or if we're talking about even individual wins. Are people's lives being changed by this? Or tell me a little bit about the successes.
Yeah, I don't think there are really statistics that point out the successes. One of the interesting statistics or facts is that sexual function for people, let's say for spinal cord injury, is probably one of the most important issues that patients want addressed. And that other than sort of maybe the paralysis of not being able to walk, sexuality is right up there as a priority for them. In terms of the successes, my success is seeing couples who have positive adjustment, who go back to work after, in spite of a disability, who are able to sort of be in relationships, are able to get married, are able to have children, and sort of live a quality of life after these devastating injuries.
Have you ever gotten some letters of thank you for,
Yeah. I've gotten letters of thank you and pictures of babies, that type of thing, and it's great.
Oh, that's great. That must be very satisfying.
That is. It's really important.
So we talked a little bit about the male. Are you doing anything specific for the female?
Female sexual functioning is obviously very different than male. There really are no medications today that address or that really will improve sexual functioning for women. There have been a lot of studies. When Viagra first came out in 1993, people thought that somehow Viagra was going to be beneficial to women, improve blood flow to the clitoris and vagina. But all the studies have really demonstrated that it's no more effective than a placebo. So that there really is a limit in terms of sort of what can be done with female sexual functioning. For most people with a disability, there's a lack of sensation, perhaps in the genital area, and that's true for women as well. Women, however, can get pregnant very soon after these injuries. But I would say that the big psychological issue for women is my boyfriend going to want to be with me, given my limited ability to please them sexually. There's a lot of anxiety about going out, meeting a man, and getting into a relationship or keeping a relationship that they may have been in when they got hurt. So I'd say the primary issues for women do tend to be more in the psychological area.
So basically what you're saying is it's really us guys that are getting in trouble.
I mean, women, the women don't have to obviously worry about erections. But again, they're paralyzed. They have no sensation in the vagina. They feel like they're not able to sort of squeeze the muscles in the vagina. They don't lubricate in the same kind of way. And all of these people, I mean, some of the issues that I deal with them is that bladder and bowel functioning, for example, they have no control over bladder and bowel issues. And so that the possibility of having a bladder or bowel accident during sex is always there.
Sure.
Or they may have blood pressure issues where their blood pressure spikes during sex. So there's physiological issues. Positioning, for example. Mm-hmm. What kind of positions when you're paralyzed can you enjoy and can your partner enjoy? I mean, men, for example, after a disability, are no longer usually able to have sex in the missionary position. They just don't have the muscular abilities for that, so that they tend to have to lie on their back or on their side. And again, a simple thing like of not being able to use the missionary position for a lot of guys is sort of like it's kind of a subtle attack on their masculinity, where they sort of feel that they're kind of less than a man.
Yeah. So I guess knowing that you're not alone with these issues is probably a big factor in...
It's a very big factor.
Yeah, in getting folks to seek help, I would imagine, right?
One of the things that we've done is to get people who have been injured previously to come back into hospitals as a peer counselor, as a peer supporter, and sort of share their stories and their triumphs and their successes or their techniques with people who are newly injured. I think that that's probably one of the most important things that happens is for a new person who has one of these devastating injuries, if they can talk to somebody who's sort of made it, that gives them a sense of hope and sort of the knowledge that this is possible and that there's something they're going to be able to overcome as well.
Well, and I imagine that erectile dysfunction is not a new thing. It's probably been around since the dawn of time. But we are talking about it because there's commercials on TV that sort of talk about it. There's ways to get around it. So that's a little bit more of a comfortable conversation, I would assume.
Yes. It's a lot easier to talk about it now than it was 20, 30 years ago. I think, again, one of the things that Viagra did, as well as AIDS and other issues that we've dealt with over the years, is that it has brought sex sort of out of the closet and sort of into mainstream conversation. I mean, before Viagra, nobody talked about it, but one slide I have is of Newsweek magazine with Viagra, can a pill cure erectile dysfunction? I mean, it's in your face these days.
Yeah.
It's not such a taboo subject anymore.
Right.
Lotsofmaps.com. Vintage, local, national, and world maps for an affordable price. 99% of our maps are $25 or less. Great as gifts. Frame them or put them under glass for your home, vacation home, or as a memory of a special place. Lotsofmaps.com.
You're now doing some international consultancy and dealing with the medical community. What kind of things are you doing? Workshops and such. What are you physically showing these folks?
I am doing a lot of work in Africa and in Southeast Asia, training people in developing countries how to provide these kind of services. These kinds of services are sort of commonplace, we'll say, at this point in rehab hospitals in the United States and maybe in many of the European cities. But throughout Africa, throughout Southeast Asia, and other countries such as Japan, for example, it's not commonplace at all. And again, having a psychologist involved with these patients is not something that is typically done. There's an emphasis, obviously, on the physical improvement, physical therapy, occupational therapy, speech therapy, but very little attention is really paid to the psychological issues. And again, what we've been doing is training these hospitals to address psychological issues, the importance of psychological issues, and again, the importance of sexual issues. So we've gone into hospitals, setting up training programs for the nurses, for the physicians, for the staff, doing support groups, training some of their patients how to be peer counselors around the sexual kinds of issues, and have done that really over the last 10 years or so. One of the things that I'm very happy that we've been doing is I was the chair of a group that developed clinical practice guidelines for the Paralyzed Veterans of America on, again, how to address sexuality in hospitals in the U.S. And over the last 2 years, the World Health Organization has also developed standards of care. And I've been involved in developing kind of standards of what needs to be addressed in terms of psychology and sex in developing countries that are beginning to look at developing rehabilitation hospitals. Many countries, such as Africa, there are no rehab hospitals. People, they often die. They fall from trees. They're in motor vehicle accidents. Without the ambulance system, often people die sort of before they get to hospitals. And if they get to a hospital, typically they really don't get any rehabilitation. They're there for a couple of weeks. They don't have wheelchairs. They're carried home. They're put into bed, and they probably never leave their hut or their house. And the discrimination against people with disabilities is unbelievable in many of the developing countries. So, again, the World Health Organization is developing standards of care, both not only in terms of psychology, but in terms of medicine, nursing, and the other fields, physical therapy, where health ministers in these developing countries can know what is critical, what's essential in providing what kinds of services to people after they have a disability.
Let's say there's a country that's not really doing this yet and not really talking about sexual dysfunction. What are the struggles that you're having as far as buy-in from the medical community, or are they having a problem even asking the question to patients?
Again, I think like I talked about here in the United States, patients want this information. You know, I've spent a lot of time in Bangladesh over the last several years. I've been in Saudi Arabia a couple of times, and Vietnam many times. And again, the patients want the information, and the doctors and the nurses realize that there is a need for it. They're just not sure sort of who should address it, how it should be addressed, when it should be addressed, what they should be talking about, how they should be talking about this to patients. So I come in, or myself with a group of other people, and we start training programs to sort of answer some of these issues. So I think the hospitals do know that the patients want it, but they just are not sure how, where, and who should be doing it all.
So are you finding success in that, the approach to the patient itself being a problem, asking the right questions? Are you finding that the medical folks in those countries are doing the work as far as asking and getting some good response, or is it still a struggle?
They've come a long way. I do think that although it's important to patients, that especially in developing countries where the values around sex are so focused on the family and private, that people have a hard time asking healthcare providers about these kinds of things. So that, part of the training that we provide is healthcare providers can't wait for the patient to be asking these questions, because they probably are not going to be doing that.
Right.
They have to be proactive and sort of bringing up the topic, helping these patients address. And the same thing here in the United States. Doctors, nurses, they always should be asking patients about how is this condition affecting your intimate life? How is it affecting your marriage, your ability, your dating, whatever, your relationships, etc. Again, typically that's not really addressed. Although more and more, I would say that there are psychologists, mental health people that work in pediatric offices and work in primary care offices where they're paying more attention to the mental health issues sort of patients. I think we've sort of realized, in colleges and across the board, just again, how important these mental health issues are.
Let me ask you a future question. Where do you think this study is going? What's the goal you think in long term? Is there something that you want to see done, or are there procedures that are still sort of out there that might someday make it to the mainstream, or what's the future of this industry?
I mean, I would like to see these training programs sustained where people are getting these kind of services. There's a lot of issues around infertility. A lot of patients around the world who have disabilities want to have kids after they have a disability. And it often involves medical procedures to extract sperm from the man and to artificially inseminate the woman. And many of the hospitals, especially in, again, developing countries, don't have the technology, don't have the expertise to be doing these things. So there's still a lot of work that needs to be done in terms of just sort of bringing people up to speed in terms of what's available in countries like the United States and sort of making that available to people in other countries as well.
I know you'd probably want to see some growth in the amount of work and the amount of people in this industry actually do more work. I'm curious about who is holding back that issue. Is it a money problem? Is it insurance companies? What's happening there?
There are many different issues. I would say it's a money issue. As a sex therapist, for example, many of the insurance companies don't pay for sex therapy for individuals. If somebody has a problem with erections or whatever, there's a good chance that they're going to have to be paying out of pocket. In terms of the hospitals, hospitals tend to focus, unless it's a psychiatric hospital, they tend to focus on the physical aspects of their patients. They are still reluctant to spend the money on a mental health provider. Thankfully, there are professional organizations, whether the National Association for Social Workers, the American Psychological Association, there are sex therapy associations that are advocating and lobbying, to try and get these types of services more mainstream into hospitals and schools and other places where people need those services.
I mean, clearly this is a specialty and probably won't ever become a mainstream type of physician, but it would certainly be more welcomed in other areas if it were more, reachable from most folks, I would imagine.
And I would, not to get too far off the field, but I've done a lot of work with transgender individuals at Boston Medical Center. We have a transgender program there. Again, not to get too far off, but the politics these days are certainly playing a big role in terms of how LGBT and transgender people are being treated and are sort of being put in very vulnerable positions. There's a lot of violence against LGBT and transgender people, and again, I think the political situation also plays a role.
As far as holding back.
And not sort of accepting these individuals.
Yeah, that's very sad. Stan, what about sex addiction? Is that part of also what you do?
Since I've retired from the hospital and, as I said, I now have a telehealth practice, I am focusing pretty much completely on that. And sort of out of control sexual behavior, especially kind of use of pornography, is a real issue among children, among adolescents, I think among everyone. And often, I see a lot of people who start off sort of with issues around pornography, but from my experience, it always escalates. Soon, just looking at videos, looking at pictures is not enough to get the kind of hit that people are looking for, and that it escalates into sending pictures or sexting with people or paying for sex or going to massage parlors or getting involved again in sort of some kind of sexual behavior that's very easy to get out of control. I see a lot of people who can spend literally 5-10 hours a day looking at pornography to the extent that they can't function at work, they're dropping out of school, and that it's sort of becoming sort of the primary issue in their lives. When people are involved in this kind of behavior, let's say they're watching pornography for hours at a time, they're basically keeping themselves on edge. They're not letting themselves have an orgasm. They sort of are edging for hours. They're training themselves to have sex to reach an orgasm in a way that is really not compatible with sex with a partner. So that these kinds of behaviors very quickly get out of control and are very destructive in terms of a person's relationship or their marriage. And again, it can be a real issue that I see day in and day out.
How are they driven to this? I know that's a general question, but why is this such a draw?
Well, I don't think there's an easy answer for that. Many of the people that are driven to this have had some kind of sexual assault or trauma as children, and they were sexually abused. Other people were exposed to pornography at a very young age before they really knew how to handle it. And again, sort of it continued to sort of intensify and became kind of a way for them to escape, like any addiction, like drinking, like gambling, like alcohol. Sex addiction is a way of avoiding reality. It's a place to go when you don't want to deal with feelings that you have, when you don't want to deal with stress in your life, when you're bored, and or when you're trying to avoid things. So that it becomes very quickly becomes a pattern of how to cope with stresses in life, with issues that you don't want to face. And again, it doesn't take long. Your body craves that dopamine, those brain chemicals that are produced at times of pleasure, and you're driven to just continue to flood your brain with these chemicals.
How are you dealing with these folks? What's the approach? I know that's, again, a general question, but what is the approach? I mean, obviously you're trying to wean them off of that situation, but is it more of, hey, we need to address your trauma a little more to try to figure out?
Well, usually when I see people, it's because their trauma they've hit the bottom. Their wives, their girlfriends have discovered their trauma. That maybe they've been paying for sex or going to massage parlors or have been engaged in sexting and sending pictures, whatever. So there's several issues, several ways to go. As I said, there often are sort of underlying psychological issues. Somebody that has been abused, somebody who has post-traumatic stress as a result of an early childhood sexual experience. So those kinds of issues need to be talked about, need to be addressed. And that doesn't just sort of happen, in a one-time meeting. You could be talking to somebody for years for that. So it's important to figure out what's the underlying issue. Is there depression? Is there anxiety that they're not able to cope with? Why are they sort of escaping reality? Are they unhappy in their relationship? So I sort of need to address those issues. And then I try and work with the person in figuring out what triggers these kinds of behaviors. When do people turn to porn? When do people start acting out sexually? Is something triggering that? They need to be able to recognize when they're getting triggered so that they can sort of take alternative actions, maybe go to the gym or do something else, get away from the computer. These people are really addicted to the screen time. Once you're into the porn, there's no turning back until you have an orgasm. So that they need to be able to sort of recognize sort of when that urge, when that drive first starts, so that they have some control in trying to change sort of the course of where it's going to lead them. So I help them identify that. Also, let me just say there are support groups all around Boston, all around every major city. Sex and Love Addicts Anonymous, Sexual Addicts Anonymous. These are 12-step programs that are designed like AA, and people attend these just like AA on a daily basis. They're a good way of getting. So I try and get people to get involved in groups, doing things like meditation, doing things like writing in a journal. Those kinds of things can also be very helpful. Sort of having a sponsor, having somebody to turn to when they're ready to act out or when they're ready to see a prostitute or something. Those are all also sort of important. You've got to sort of develop some alternative actions for people to take at those times.
So I know there are resources out there for folks that are having sexual dysfunction in all kinds of fields. What do you think the first step should be for somebody who is having trouble and they just don't know where to turn?
I'd like to say that the first place they should turn is to their partner, if they have a partner. Part of the issue why people can't deal with these things on their own is that there's no accountability. It's sort of their secret. It's kind of their whole secret ritual that they do, sort of that there's their own little way of kind of seeking sexual pleasure. If they can tell somebody, if they can tell a partner, that's an important first step. And they should start seeing somebody professionally. There are medications to help. Seeing a psychiatrist is a good idea. There are medications that can help them, maybe medication for the depression. There are also some medications that sort of, these are really obsessive compulsive disorders in a lot of ways, and there are medications that can be helpful sort of in reducing these kind of compulsive behaviors. They should also get involved in, as I was saying, these 12-step programs are great. It's difficult for people to sort of admit they have a problem, to present themselves in that. But a lot of these programs are now available on Zoom so that, again, they can participate in them without going in person. It provides a degree of anonymity.
So would you suggest, as far as getting help psychologically, would you suggest contacting your primary, starting there, and have your primary sort of guide you if you don't know where to turn?
That's a good way, turning to your primary care doctor. One of the major ways that people are finding therapists these days is a website called Psychology Today that's put out by the Psychology Today magazine. And more and more people are, and there are other ones as well, but Psychology Today is probably the biggest one these days. People are turning to that to find therapists. And that is good because it sort of specifies what the therapist specializes in. So it's beneficial. People should also probably think about getting references from their insurance company, because obviously people want to have this kind of covered if possible. So the insurance companies maintain a list of sort of providers who are part of their insurance networks, and it's a good way of getting a referral as well.
So obviously admitting that you've got an issue, whether we're talking about erectile dysfunction or a sex addiction problem, the first step is admitting you've got a problem and looking for someone to turn to that can help you, I would assume.
Which is no easy thing. I mean, there's so much shame associated with this, and guilt and shame and depression, that admitting that you have a problem here is a huge undertaking. But like you said, it is the important first step.
Absolutely. And I'm sure folks, if they realize that they've got an issue, a cure for that or something to at least help is not that far away.
A lot of these problems start as teenagers, start around puberty, and they go for 20, 30, 40 years. I mean, and people sort of feel that they feel hopeless. But again, as you said, there is hope, and these things can be treated, and they can be addressed and turned around.
So, Stan, it's you work in a very unusual subject matter. I got to ask: is there anything inappropriate or funny that might have happened during your career?
Yeah, I've had a number of different odd situations arise over the years. As I was telling you before, my wife and I used to do workshops at BU Medical Center on sexuality. And when we were doing those, part of what we needed to obtain was a lot of X-rated movies and videos. So typically I'd buy videos and movies in San Francisco. And over the years, what kept happening is by the time I get back to Boston, I would see that somebody had been through my luggage and had taken the videos out. And so obviously I couldn't report it to the authorities.
So they actually stole them.
They actually stole them. So.
Would that be considered deviant, behavior too? And is there a therapy for that?
I'm sure there is. Anyway, that kind of leads me to an event that happened about 20 years ago. I traveled to India a lot over the years, probably 20, 25 times. And the medical director at the Indian Spinal Cord Injury Center asked me during one of my visits that if he gave me $1,000 or $1,500, would I be able to bring back the next time I came to India some of the paraphernalia, vibrators, dildos, sex toys that were available here in the U.S. At the time, they were not available in India, and it was before the internet. So I said, sure, no problem. So I spent about $1,000 buying vibrators and dildos and handcuffs, you name it. And because I had my luggage, the video stolen previously, I decided to carry it on in my carry-on luggage. So I didn't think twice about it. I thought it was a good idea. So I arrived at the airport, and of course, you got to go through TSA.
Oh, no.
And a lot of these vibrators, of course, battery-powered, and so you got wires everywhere. And so I put the suitcase through, and it didn't last long, because right at the other side, we've got to open this and inspect what you have here. And opened it up, and the guy's eyes were bulging out. And he said, hey, to some of his other cronies, hey, get a load of this. And a bunch of other passengers and the TSA people. So TSA made me take the vibrators and dildos out one vibrator at a time, turn it on, and put it aside. It was one of the most embarrassing
I assume
funny
you,
things.
you flashed in your business card to sort of prove that you're not.
Yeah, I don't know if they believe in me, but
So I guess word to the wise: if you're going to travel with a whole bunch of sex toys, make sure you make up business cards before you do it, so you can use that as an excuse.
That's a good pointer.
Imagine if I guess I put myself in the place of the TSA agent. Could you imagine if a dildo actually brought a plane down and it went through your inspection?
Anyway,
let's talk a little bit about the field and any kind of advice you might have for folks that might want to get into this field. Obviously, you've got to start going to school. Are there things that folks can do? Are there specific college routes for this? Or what would you say would be a good advice for folks that want to be interested in this?
The way to start with this is really to start going to school sort of in the mental health field, getting a bachelor's degree in psychology, social work, and then you really need to get, in Massachusetts and in this country, you need to at least have a master's degree. There are really not schools for sex therapy or ways for undergraduates to specialize. You need to get at least a master's degree in a behavioral health, mental health field, and then you can. Then there are organizations that will provide certification and will outline specific courses and curriculums that you need to take in order to become certified as a sex therapist. But you need to first have a foundation in mental health. Like I said, you can't just treat the sexual issue without sort of being aware and hopefully treating kind of the underlying depression, PTSD, abuse issues, and all of the other diagnostic issues that are probably underneath the sexual dysfunction.
So, Standards, is there any kind of internship program or something along the lines so people can check out the field?
Over the years, for example, I've been at Boston University, Boston Medical Center for my whole career. Over the last 20 years working in in urology at the Center for Sexual Medicine. We have many students come, graduate students in psychology come, do internships, externships, co-op students like from Northeastern who come and want sort of get exposed to the field and sort of see what it's about, see what we do as sex therapists in these kinds of fields. So a good thing would be to contact some of the hospitals, again, the transgender program at BMC or the other hospitals, Fenway Community Health. There are a lot of great places that work on sexual issues that do take students as interns or as co-op students.
So, Stan, your day-to-day, I know, has changed, obviously, since you've officially retired and all, but other than seeing patients and doing some speaking engagements, what are you doing as far as your own research into what's happening in the community that you're in? What other things do you need to do? Are you writing? What is it that you're doing these days?
Like you said, it is important to sort of stay current in the field. So I spend a fair amount of time sort of reading professional journals as to what's going on. I attend conferences, interact, network with other people, and still do some supervision of interns at BMC through telehealth that are there for various trainings. So although my current circumstances make it difficult for me to travel to a lot of developing countries, I'm supervising people in those countries. I have just finished working with somebody in Bangladesh for a year who received an award to get training in sexuality. So I'm involved in sort of in a remote kind of way, working with interns and training people still.
So do you have somebody that's sort of taking your place at BU, and have you been training anybody to sort of do the kind of work that you've been doing all these years?
We've trained a lot of people at Boston University, Boston Medical Center. So there are people, yes, in the community that are sort of carrying on the work that we started at BMC.
Stan Ducharme, thank you so much for coming on Occupations and telling us a little bit about what you do.
It's been my pleasure, Andy. I appreciate the opportunity to come over and to explain it. And again, I hope people listening that will give some thought into whether this field might be a fit for them. It's very rewarding and very satisfying, and I certainly have enjoyed my time providing these kind of services.
And thank you for that, opening up an area that is, sort of taboo. I think that's a big thing. So thank you again for coming on the show. Please join us again for another episode of Occupations.
Occupations has been brought to you by lotsofmaps.com. Please follow Occupations the podcast on Facebook, Twitter, and Instagram to find information about our next episode or to see what past episodes are available.